Okay, great. Well, hello everyone. Thank you for joining us for today's live talk by Dr. Jill Barber. She is a reader in School of Health Sciences and is currently part of the Centre for Applied Pharmacokinetics research. So just to give you a bit of background, so Jill has got chemistry background and her research focuses on proteomics, which aims to characterize and quantify the proteins responsible for drug metabolism and transport in humans. So in her talk, which is titled How to Build an Avatar and What It Can Do for You, she will be telling us how you can get the right dose to the right patient and how you can use this to overcome the challenges of population variability. So before we start, for those who hasn't joined us before, I would like to tell you about our ducture. So first of all, we're going to start with a 45-minute talk, followed with a 10-minute break during which you can submit your questions to Jill. And after this break, we will then resume and I will be asking your questions on your behalf to Jill. So we're assuming that this question and answer session will last about 15 to 20 minutes. And that's about it. So if you're new to following Live with Sciences, please subscribe to our channel and please make sure you're following us through our website and through our social media accounts. So Jill, again, thank you very much for joining us today. And it's an absolute pleasure to have you here. And I really look forward to hearing more about your talk. Thank you.
All right, well, thank you very much, Aisha, and thank you, Scott, for the invitation. So I thought I'd entitle the talk, How to Build an Avatar and What It Can Do for You, because there have been several films where you imagine having a being that may be maybe a conscious being or may just be a robot that represents you. And we actually all like this because we believe that we're all different. And we like our medicine to be personalised for us, but we don't want people. We don't want people testing things on us. We want them testing on something else. So the great medical fallacy is that we're all the same. And I eventually found a song I've been looking for some time, Little Boxes by Malvina Reynolds. And this describes, firstly, a bunch of houses that all look the same, and then a bunch of people who all look the same. And this is just part of it. You can look it up on YouTube if you're interested. But of course, this is something that we encounter almost every day. If you look at the recommended dose on your ibuprofen, then if you're over 12, you're recommended to take 1 or 2 200 milligram tablets every, 3 to 4 times a day, that sort of amount. And this doesn't vary if you're big or little or old or young or male or female. The fallacy is that we're all just the same. We're not. So let's consider a typical student party. Now, this molecule here is, are you okay? This molecule here is alcohol, ethanol, and we know that ethanol, if you drink enough of it, makes you drunk, and you lose control. You may be stuck around it. You can't find where you're going very well. But many of us are saved by the fact that we have this enzyme in our livers, alcohol dehydrogenase. What alcohol dehydrogenase does is to change the alcohol. It oxidizes it to this molecule here, which is acetaldehyde. But there's a problem with acetaldehyde as well. It's a potent toxin, and acetaldehyde is what will give you a hangover. Well, that's pretty bad, but most of us are fortunate enough to have this enzyme here, aldehyde dehydrogenase. And what aldehyde dehydrogenase does is to oxidize the acetaldehyde further to a molecule that you may not be able to completely see, acetic acid. And acetic acid is found in vinegar, and it's just food. Well, you might think that that's great and food can do you no harm. But of course, you'd be wrong, because it's food that makes you fat. So depending on the balance of the enzymes that you have in your liver, you can drink the alcohol and you can get drunk, you can have a regular hangover, or you can nearly get fat. Now this becomes important in human health. So this is a very old set
Jill,
of data.
to interrupt. There is a problem with the sound. If you could please stand closer to your laptop, we might be able to hear you a little better.
Okay, is that better?
I think so. Sorry about this.
Okay. Yeah, so this matters in terms of human health. So this old set of data refers to alcohol-related fatalities by both gender and ethnicity, and this is done in the USA. Now you can see straight away that males on the whole are more likely to be involved in a fatal car accident than females, and when it's alcohol-related. And this is probably a social thing and has to do with men drinking more alcohol than women. But then you have the differences of ethnic groups. So if you start with the Caucasians, who I think make up the majority, they are very, very similar to African Americans in terms of the pattern of fatalities. But you see what happens with Native Americans. Many more of their traffic accidents have alcohol-related fatalities. And this is because Native Americans are lacking in those enzymes on average that we saw. And so the alcohol has a more profound effect as alcohol. Now we're all told that you can drink 1 unit and it'll take about an hour to be metabolized. But this does vary enormously depending on the state of those enzymes in your liver. Interestingly, Asian Pacific Americans, so Japanese Americans, also have reduced amounts of alcohol dehydrogenase and aldehyde dehydrogenase on average. But like many generations, and alcohol is part of the culture. And so the social part kicks in then, that the alcohol is consumed in a way that's appropriate for the enzymes that they have in their livers. And so we have this mixture of genetics and social factors that make up this rather scary graph. Now, one point about this that you might be interested in is that this enzyme, the first one, alcohol dehydrogenase, will accept almost any alcohol, and that includes methanol and antifreeze, and will convert to these toxic aldehydes. But the aldehyde dehydrogenase is very fussy and essentially will only accept acetaldehyde. And so methanol and antifreeze become very potent poisons because they get stuck at the point of the aldehyde. But alcohol dehydrogenase is competitive enzyme. It likes to have ethanol, so the alcohol you find in whiskey, in preference to methanol or antifreeze. The methanol and antifreeze are not themselves harmful, it's the metabolite that's harmful. And so you treat methanol poisoning or antifreeze poisoning with about half a bottle of whiskey. But why do we metabolize drugs? And we do metabolize drugs, not just alcohol, but many, many other drugs. And it's because drugs are recognized principally by our livers as foreign. And then what the liver does is to try to make them water soluble. So it does chemistry on these. It does chemistry on these molecules. I'm getting an echo, Aisha. I think because you're not muted. It does chemistry on these molecules to make them more water soluble. And water soluble compounds are excreted by the kidneys. And the liver doesn't distinguish between drugs and poisons. And so it metabolizes drugs just in the same way as it metabolizes poisons in an effort to get rid of them. So here are some examples. So this top compound here, efavirenz, that's an anti-HIV drug, and it's metabolized in the liver to give 7-hydroxy-efavirenz. Now, the hydroxy group is what's needed to make this thing water soluble. Hydroxy groups make things water soluble, that's what happens. And so 7-hydroxy-efavirenz is more readily excreted. Then you could have a transformation that just reveals an OH group, and that's what you get with aspirin. So aspirin is a so-called ester, this group here. And if you treat it with an esterase, you get a new OH group, water soluble, out it goes. And then we get these compounds, the uridine glucuronide transferases, and I don't think I'll say that again. I'm going to call them UGTs from here on in. And these will add a sugar to a drug molecule. So here they are adding a sugar to morphine, and look at these OH groups, 3 of them, and there's actually one buried in here as well. So 4 new OH groups becomes water soluble. So now we get the challenge of patient variability, because just as the alcohol dehydrogenase and aldehyde dehydrogenase vary from person to person, so do the enzymes that metabolize our other drugs. And this is particularly a problem in an adult population that has had all sorts of different environmental challenges. So our environment can include smoking, drinking, pollutants, all sorts of things. Genetics also has a bearing on how we metabolize drugs, and perhaps most worryingly of all, so does disease. And after all, the people who take drugs usually have some form of disease, and that can affect how they metabolize drugs. So we have this patient variability. And this becomes important, particularly where we have toxic drugs. Now, if you take a drug like ibuprofen, you can't see quite all of it. Not sure whether I can move it. Ooh. Well, maybe. You have a drug here that is therapeutic, and the difference between the therapeutic dose, the dose that kills pain, and the dose that causes toxicity is really pretty big. And that's this parameter of the therapeutic index. So that means that we can give quite different people the same dose of ibuprofen, and that's fine. They're not, we all take a small overdose when we take ibuprofen, and it doesn't matter. But if you take a drug like gentamicin, it's a big problem. So gentamicin is one of the most effective antibacterial agents known. It really does kill most of the bacteria that can invade us. The trouble is it also kills us. It has a very narrow therapeutic index. And so if you're on gentamicin, the overwhelming likelihood is that you're going to be in hospital and that the gentamicin levels are going to be monitored very closely. So this is a book I read last year, or strictly listened to on Audible. And it talks about the, it talks about a data gap because so many data sets are collected only on men, 50% of the population. And the one, of course, that we're concerned about is the drug that's wrong for you. Well, that arises because the early stage clinical trials are largely done on rats and young, healthy white blokes. And if you're neither of those things, then you potentially have a problem. Now, of course, obviously the drugs are eventually tested on people who have the relevant disease. But in the early stages, if a drug absolutely does nothing, then it will be discontinued from the later stages. And so the result is that when men are badly affected by a drug, it's usually because they have a side effect. And when women are badly affected, it's very often because it just doesn't work. So in the early stages of clinical trials, large parts of the population are simply not represented. So what do we do? If you're not a rat or a young white bloke, you can still be represented in drug trials, but you more or less have to be an in silico model. So in silico meaning in computer. So you become a computer-based model, which is something like this. And so we can build avatars in computers, and this is one built by Masood Jameh, and the avatar consists of a whole load of equations, differential equations, or put another way, it's a combination of mechanistic physiological models and parameters, which is arguably not very flattering, but does more or less work. So if we look at this more pictorially, we can see that what we're chasing down are various parameters listed here, and many of these are proteins. So there we have transporters, they're proteins. We have enzymes, we've already talked about those, they're proteins. And we also have these carriers, and they're proteins as well. And in order to make a good model, and particularly to make a good model that is good for one specific population as opposed to another specific population, we need to know how much of these carriers, transporters, and enzymes we have in livers or other organs. And so my job and the job of the people I work with is to populate these models by determining the amounts of these compounds, particularly the enzymes and transporters. So personalized medicine, or more usually precision medicine, in which people are still in groups rather than absolute individuals, but nevertheless, they're being treated in groups. What we try to do. So we quantify the drug metabolizing enzymes, and these are always known as CYPs and UGTs. I've told you what UGT stands for. CYPs is Cytochrome P450s. So that's just a name for the enzymes. And we look at them in liver, and they're also very important in kidney, in the intestine, to some extent in skin. That's up for grabs really. And placenta is the next organ we're planning to try. We also quantify transporters, and those are quantified in all these tissues, but also and crucially in brains. That is the blood-brain barrier. And we want a wide variety of patients and post-mortem tissue. So the tissue either comes from people undergoing surgery, or it comes post-mortem. And then we create our models, our avatars in the computer, and we model the effect of different drug doses. So how do you do that? Well, the samples, and they're very small samples, undergo a certain amount of chemistry, in particular here where we chop the proteins into small bits, and then we do mass spectrometry. So mass spectrometry is an analytical technique that determines the mass, the molecular mass of fragments. So put another way, it weighs molecules, and we find out how much of a molecule of a particular weight we have. And we can use that information to say how much we have of a particular protein. And so what we call the proteomic workflow has some quite bizarre characteristics. We take a mixture of proteins, and we will be detecting several thousand different proteins. So in order to make it easy for us, or easier, we chop them up using a digestive enzyme. Now, this has been likened to taking a 1,000-piece jigsaw and then putting every piece through a shredder. It is really quite counterintuitive. But what it does is to get the proteins into smaller, more manageable bits, and bits that have just have a defined structure. They have a basic residue at one end, and that just makes it easier for us to detect and quantify. And then they go into the mass spectrometer. Now, the models that we deal with are very, very data hungry. The more information they have, the better they like it. And so now we get the problem with mass spectrometry, that there's really no way of checking that we've got the numbers right. Well, we can use antibody-based methods to understand these quantifications, but they're very slow and not always very specific. They're not very quantitative, and they're certainly not very kind to animals. Mass spectrometry is exquisitely sensitive. We can detect down at 10 to the minus 15, 10 to the minus 18 molar concentrations. So that's only really a few thousand molecules. They're very selective. We can distinguish one from another, one molecule from another, really very, very well indeed. We don't use animals in any form. But it has to be said, NMR, another technique, is like your mother. It always tells you the truth. Mass spectrometry is like your lover. It tells you what it thinks you want to hear. This is said many times by Ian Wilson from Imperial College. His neighbour at Queen Mary, Simon Gaskell, very diplomatic. The relationship between the size of a mass spec signal and the concentration of the analyte is complex. I think I just suggested to him that it was non-existent when he said this. It's somewhat disputed whether Rob Bainin actually said this. I'm trying to find out, but it's like quotes attributed to Winston Churchill. It would be quite unsurprising if he did say it. If it weren't for its sensitivity and selectivity, there would be no justification for mass spectrometry. Or if you're trying to get things right, then you get the quotation from St. Paul, work out your own salvation in fear and trembling. And to illustrate that point, somebody back in 2008 tried to quantify every protein in E. coli, and it emerged really that the top protein, there wasn't enough room for it in the cell. It had gone really rather wrong. So what have we actually done? Well, we've quantified CYPs and UGTs. In fact, they've been quantified many times, and we're beginning to get a picture of the amounts that we have in livers. Now, these look like error bars. They look like the variation in measurement, but actually they're not. They're an indication of the variation between individuals. So some individuals will have almost none of these enzymes, and some will have hundreds of times more. Most people live in a particular area, but some do not. And the clinical result of this can be that you can get drug interactions. So if you're on a statin and you're taking erythromycin, you'll find you'll be told to discontinue your statin while you're taking the erythromycin. And that's because the erythromycin, which you take quite a big dose of, will clog up the entire amount of this CYP here, and you then overdose on your statin. So you come off the statin while you're on the erythromycin. You then get other interactions between beta blockers and antidepressants, for example. And so you have to be rather careful if you're taking a lot of different drugs. So we talked about the enzymes, but we also have the transporters. And so we have transporters that bring the drugs into the cell. So these are OATs and others. And we have transporters that take drugs out of the cell. And one of the most important of these is PGP. It's present in the blood-brain barrier, and it's and Alzheimer's disease is associated with reduced amounts of PGP. And so we can do what are called virtual clinical trials. We can build up our models, and then we can say, well, we'll use our models, our avatars sitting in our computer, and we'll do something like a clinical trial using the model. And this has now become quite widely accepted, and there's nearly 100 drugs which are informed by these virtual clinical trials. And you can see some of them here. So some of the studies that we've done include looking at CYPs and UGTs in the healthy human liver. And so this has already become an avatar in a computer, and we can already use these data to conduct virtual clinical trials. And you actually get correlations between the amounts of these different proteins. So someone who has a large amount of one of these proteins is quite likely to have a large amount of another. and we can see the correlations here. And this work's been done by Brahim Asher, one of the postdocs, and he's shown here. We've worked on the blood-brain barrier, particularly looking at the transporters. Now, this is more recent work. It hasn't actually reached the models that are widely used yet, but this was published just last year. It will reach them. And this is looking at the transporters in the blood-brain barrier. And crucially here, we've linked the preclinical species, the rat, to the human. This is a phenomenal effort in terms of experimental work. And this was done largely by Zubaydah Al-Majoub, who's shown there. And she used 3 different mass spec methods so that she could confirm that her abundances were genuine, and they show really very good agreement. But you can see what you start with is taking whole brain and isolating these tiny little microvessels, and that's where you get your protein that you're going to quantify from. So there's her correlations between one measurement and another, and you can see they're really good. And then we did a crazy thing which worked rather well with these data. So we thought, well, we've got 22 human brains. And so if we look at one protein, we're looking at just 22 data points. And we're maybe not going to be able to see very much from that. But if we look at all the proteins and just say, well, what's similar and what's different, then we see something quite exciting. So if you look over here, you can see that we form a cluster between one of the 2 dementias we were looking at, dementia with Lewy bodies, these are the blue dots, and most of the healthy patients. They're all in this cluster. The Alzheimer's patients are mainly outside the cluster. Actually, this means they're scattered to the 4 winds. This isn't a cluster. But just a few others are also outside the cluster. We then looked at the characteristics of these others that were outside the cluster and found that they were the oldest patients in the sample. So this is fairly remarkable. We've got the Alzheimer's patients lying outside the cluster, all but one, and we've got some of the oldest patients in the normal group also lying outside the cluster. So we don't quite know what it means yet, but we're certainly seeing differences. At the other end of the scale, we've also worked on children's liver disease. So biliary atresia is a rare condition. As rare conditions go, it's relatively common. It affects 1 in 5,000 to 18,000 live births. And it's inflamed or obstructed bile ducts. And so the symptoms occur very early in life, when the baby's just a few weeks old. So the baby will be jaundiced. And our collaborator in Leeds, Navid Alizai, does corrective surgery, and he does an enormous amount of this corrective surgery, a Kasai procedure. And he takes a little bit of intestine and he puts it where the inflamed bile duct should be. And these patients eventually all need a liver transplant, but the purpose of you doing this procedure is that it means they don't need the liver transplant until they're in late adolescence or even early adulthood. And then there's a nice big window where the transplant will be effective. The doctors can see that they're going to need a transplant maybe in the next year, not in the next week. So it's a very helpful procedure. And Navid is one of those surgeons who doesn't throw things away. and he's kept all the liver tissue and also the spare intestinal tissue that he takes. And we've used the liver tissue from several patients, though not yet the intestine. And this work's done by Martin Howard, shown here. Martin passed his PhD last week, so he's now Dr. Howard. This is his PhD work. And you can see that here we have, it's a little bit hard to see, the diseased, very young children, and they've got almost no cytochrome P450 2b6, whereas the controls have got a reasonable amount. Even more marked in the infants, where you've got, so the children are a little bit older, where you've got the biliary atresia infants still down here, almost no 2b6, whereas the infants in the controls are beginning to acquire it. So what's a control? That's a very difficult question, because you're not going to get children queuing up to have a liver biopsy. And in fact, although we call the biliary atresia diseased and the controls healthy, they're nothing of the kind. The biliary atresia patients are still alive, whereas the controls, the so-called healthy, are actually dead, because we've managed to get these livers as a result of deaths from other causes. We assume that the livers are healthy. So this is Navid, shown here. So he's not only this very enterprising surgeon, he also actually has run several marathons on behalf of the charity that supports this work. And what we see is that when they're neonates, although the actual amounts are reduced in biliary atresia, the proportions of these drugs are proteins are fairly similar. But when we go to older children, we can see that the biliary atresia infants, they're retaining the fetal CYP3A7. This is a fetal enzyme which goes down in normal livers. So it looks as though the liver is just not developing in these children. Now, this is really, really important, because these children are on pain medication. One of the drugs they might be given is paracetamol. Paracetamol is metabolized in the liver of adults and even of infants to toxic metabolites. And so this is how you get paracetamol poisoning. But paracetamol itself is not toxic. So this may be good news. It may be possible to give biliary atresia infants a little bit more paracetamol than would be tolerated by normal infants. We have to work that out, but that's what it looks like. So we're building the biliary atresia infant avatar. We've done work on intestine and skin as well, which I won't go into, but this has been led by Zubaida and also by Narciso Couto, who is shown here. And what we're now working on is better analysis, better sample preparation. That's the whole group. Very exciting bit of work that Brahim is now working on, using blood plasma to understand liver function. So rather than biopsying livers, actually just taking blood. And of course, this is great because people will donate blood as controls when they won't donate bits of their livers. Zubaida is involved in comparing the liver and gut. Are the proteins that work in the liver and gut actually similar? And then we have 3 students who are currently rather held up because they can't get into the lab. But Eamon here is trying to make an avatar for liver cirrhosis, largely to understand how people with cirrhosis metabolize drugs that are not for treating cirrhosis, but for other things, like breaking a leg or something like that. Areti is in the middle here. She's doing something similar for liver cancer. And then Sarah's taken on a very difficult project where she's looking at Crohn's disease and looking at the intestines. And then Nora, the new student, and I don't have a photograph for her yet, is trying to understand how genetic differences play into all of this. So she comes with a background in genetics. So the conclusions are that we can use proteomics together with systems models to build computer-based avatars, not yet to represent individual patients, but certainly to represent groups of patients. We can then conduct virtual clinical trials, so we can try to understand how to treat a broken leg in somebody who's, for example, also diabetic and pregnant. In other words, how to dose drugs, how to get the right dose for anyone who's neither a rat nor a young white bloke. So the data sets we have so far are usable, but the whole technology has only been available since about 2008. So they're usable, but they're still subject to a lot of potential error and still requiring a tremendous amount of work. So we're learning all the time. Basically, we're quite good at CYPs these days, Cytochrome P450s. We can get quite good information from a variety of tissues. We're rather less good at UGTs, and for those of you who would appreciate this, it's partly because the UGTs are absolutely embedded in the membranes, whereas the CYPs are attached to the outside. Transporters we're less good at still, because it's very difficult to isolate the membranes in which they're embedded. So at least we can isolate the relevant membrane for UGTs, but transporters are that bit more difficult to gain. But we're working on them. So acknowledgements, I've spoken about, I think, all of these people, and the other person who leads the group, my collaborator and friend, Amin Rastami. So Amin is the the modeling expert in the group. He also these days knows a good bit about the proteomics as well. It's a great pleasure to work with Amin. SimSip is the company that Amin actually founded. And this does some modeling. Two of the people we work with here are Matt Harwood, who used to be in CAPCA and is an intestine specialist, and Sibylla Neudorf, who essentially knows everything. Leeds General Hospital, we collaborate with the surgeon Navid Alazi, and that's a great collaboration. The funding, of course, is vital. We do get funding from Satara. They're funding Brahim's project at the moment. Childhood Liver Disease Foundation funded Martin's project. The Centre for Applied Pharmacokinetic Research, CAPCA, is a consortium which is supported by 9 industrial companies, 9 pharmaceutical companies. We've just landed a grant from Cancer Research UK, which we haven't started our bit on yet. Similarly, the European Union, and we'll be working on peritoneal cancer and polycystic kidney disease. And then Areti's project is supported by Merck in Darmstadt. So thank you very much for your attention.
Lovely. Thank you very much, Jill. And I do apologize. We did have some sound problems, which sounded like, which looked like when I was muted, it was being aggravated. So hopefully everyone was able to hear your talk. And it was a very interesting talk, Jill. We already have questions coming through our social media channels. So if we break now for 10 minutes, would that be okay to come back at 7:25 for question and answer session?
It's fine by me. Yeah, yeah. Oh, I hope I didn't.
Lovely. So
I
anyone
start
who's
sound.
watching, lovely. Anyone who's watching, please keep submitting your questions either through the YouTube channel or through our social media accounts, and we will resume back at 25 past. Thank you. Hello, everyone. Hi, Jill. Are you actually to get started?
Unmute. Right. Yeah, so you still, shall I stop share or?
Yeah, that's a good idea.
Right.
Nice, great. Great, so we have some very interesting questions. I'm going to start with one of my questions, just as an opener though. I was wondering, could you please tell us a bit more about what does these CYP enzymes or UGT enzymes do in terms of drug metabolism?
Okay, so I talked about them, the CYPs really oxidizing things in order to make them more water soluble, and the UGTs are sugar residues for the same purpose. Beyond that, it's a bit bewildering. So, for example, clarithromycin, which is very similar to erythromycin, is metabolized quite differently by the same enzyme. So erythromycin loses a methyl group, becomes completely inactive. Clarithromycin gains an OH group and becomes more active. They're very, very hard to predict in detail. The one thing you can say is that you're likely to get increased water solubility.
Okay, thank you. So during the break, we had several different questions. So I would like to start with one of our watchers' questions. So they're asking, is it likely we will soon have ultra personalized drug treatments based on these models as a routine? For example, are we going to be able to have a blood test to measure our enzymes and the computer will spit out an optimized dosage for that patient specifically, for their condition specifically? I think you're still muted.
Right. I mean, that's definitely an aim. Is it going to be very soon? Probably not. So the liver data that we got is now in models, and that data comes from 2014. Our 2019 data is not yet in models. Gives you an idea of the sort of timescale it's taking 4 or 5 years to get good data into models. Right, now, you also asked really about whether it could be completely personalized from taking a blood test. I'd sort of hesitate to say yes straight away, but we're certainly moving in that direction. We're certainly finding that you can say things about the liver based on what you can see in plasma. So taking a plasma sample, understanding the balance of enzymes in the liver is being done in a sort of laboratory setting at the moment. So we have published nothing on it, although I've seen a manuscript, and I do expect things to be happening really really quite soon, and I'm just a little bit hesitant about saying too much because it's not published yet. But well, I think we're certainly looking at decades, not years. But it's not a stupid thing to hope. As to treating the actual disease, though, that's a particularly interesting one, as opposed to treating what we call comorbidities, because obviously you do test Alzheimer's drugs in Alzheimer's patients. So there is a certain amount of primary data for which you don't need a model. What you don't test in Alzheimer's patients is, say, drugs for epilepsy. And it's more these sort of things that we're concerned with. So you've got slightly better data anyway, if you're talking about the primary condition.
Okay, so thank you very much for that. So how do you, if we say that we're going to be in that position in a few decades time, what would be the perfect combination of factors that you will have in place to have that? Obviously, you will need to have the technology, but what else would you need to get that in place? Do we need any changes in our policy? What else can you name in terms of that? I'm not
an expert on policy at all, but from my perspective, I'd hope that we were taking a plasma sample, turning it round in a few days. At the moment, that's realistic. Let's say a week, and then coming out with a picture of what's in the patient that could then be modelled. That would also probably, at current rates, take a few days. If we had the model already basically prepared and we just had to tweak the numbers, it might even be quicker than that. We need improvements in our mass spectrometry technology, and that's coming all the time. But then you have to bear in mind that each of these instruments costs about $1 million, and it takes several hours to run one sample, and the running costs are high as well. So it's costly. There's no question. Yeah. I've just thought actually.
So at the moment.
Yeah. Sorry.
Go on.
Well, I was just thinking actually we possibly would be looking at analysing RNA rather than protein, but that's costly as well. So it doesn't matter. It's still, yeah, same difference.
Okay. All right. Thank you. So, for example, if we were to, this is again a question that's been submitted by one of those who has been watching the talk. So, for example, if we get people who are on long-term medication or who are having to use, let's say, antibiotics for extended period of time, or different types of antibiotics in combination. So if they're using these drugs in a long time, and we know that some of these drugs can actually affect the activity of these enzymes as well, how, is there any evidence showing that long-term use of drug X can have an effect on these enzymes? And if so, is there any way of actually improving the activity of these enzymes other than just stopping the treatment?
Okay, well, yes, you can induce an enzyme by using a drug drugs. Some drugs induce some enzymes, no question. Can you improve the activity? I guess really it's just about understanding things, what's going on. So people on certain drugs are told not to drink grapefruit juice, and that's down to the grapefruit juice inhibiting, competing out the drug from relevant enzymes. The result being that you overdose on the drug that you're on. typically a statin. So you could argue, in fact, that it might be better to make the grapefruit juice compulsory and then use a smaller dose of the statin. So yeah, things do go on. I'm not sure I'm completely answering the question, but I'm getting close. What do you think?
Yeah, I think it's good enough. You know, obviously there are other factors, whether, you know, it might be something with diet or anything like that. But I suppose there needs to be long follow-up studies to actually find out what is the exact effect of each drug if they're used for 6 months, for a year, for 2 years. And it's good to know that as being enzymes, we can actually induce or manipulate their activity in some shape or form. But do you think it's possible to have a complete control over it?
No, probably not. Not realistically, in this sort of timescales. No, the science will always take us by surprise.
Yeah. Okay, thank you. So, so based on your talk, then, does this mean, you know, the information that you already have, the research that you're doing, the new knowledge that you're, you know, getting out or finding out every day, does all of these all together mean that we are a step closer to be able to use a person's genome to predict how they will metabolize drugs? Or is this only possible through testing tissues?
Okay, that's a really interesting question. And I'm getting horrible feedback here. It's quite disconcerting. Okay, so the genome will tell you about what version of a particular enzyme somebody is producing. It can't easily tell you how much of that enzyme they're producing with present technology. What you need to do is to get in at the level of the protein in order to understand how much. Now, Nora's project, where she's looking at the genes, will, we hope, throw a bit of light on this, because sometimes we think that an enzyme is, we think that somebody is producing a poorly active enzyme, when in fact they're not. They're producing an enzyme that's completely active. They're just not producing very much of it. So at the moment, and I think for the sort of foreseeable future, we need both the genome and the proteome. And in fact, the proteome will tell you everything you really need to know about the genome. But genomics is easier. There's no question. And so if you can get away with understanding just the genome, you probably should.
Okay, all right, that's great, thank you. So when it comes to looking at these genes and, you know, any changes that you might have on these genes which are manifesting themselves in the enzymes, and therefore you have a differential activity of the enzyme, do you think we can only get these type of modifications by birth, so we are actually inheriting them from our parents? Or is it actually possible to get these type of changes on these genes somatically, so, you know, during our lifetime?
I'm not aware of changes during a lifetime. Which doesn't make it impossible, but I'm certainly not aware of untoward events causing changes like that. I'm not sure some of these things. I don't know about the turnover. As far as I know, the differences in the structures are down to the genome, the genome you're born with. But I wouldn't. I'm not 100% confident about that.
Okay, all right, thank you. So if you're not too tired, I've got a couple more questions to go through. So
sorry,
I was just saying, if you're not too tired, we have got a few more questions to go through.
That's fine.
Yeah. So we've got another questions from one of the people who watched the your talk today. So they're asking, what's missing from your models at the moment, and how might you fill in the gaps?
Data, just more of the same. We just, if you've got these very high variabilities, then you need a lot of data to feed the models. In particular, we want data that are from non-Caucasian populations, and the difficulty here is, as you can understand, it's because we're looking at tissues, we can't readily get the tissues that we would really like. And in fact, I had a long discussion with a grant awarding body on this, where they said, well, can't you prospectively get controls for biliary atresia? And the quick answer to that is not without a machine gun in a nursery. You can't. You're relying on opportunistic samples all the time. So we want more and more data, and then the next limitation is cost. So the brain bank isn't actually accepting more brains of certain sorts at the moment because it's got enough. People have been very, very generous, but we don't have the money. I mean, we're estimating it costs £700 just in consumables to look at one brain, and that's after you've paid for somebody to isolate the blood-brain barrier, which is no easy feat. So that's the other big limitation, that we need more skilled people and more money. But yeah, if you talk about livers where it's where we've got everything worked out, it's as inexpensive as it's ever going to be. I think we could just do with more samples from a wider variety of different populations.
Okay, thank you. So one last question though. So obviously these changes in enzyme activity, or these variations that you've seen, are generally causing problems. They're rarely causing an advantage for us. So how do you think, considering that how long it actually took us to evolve over time, and always in terms of selection, you always get something that's favorable for our being to carry on. So how do you think we have ended up with these genetic variations that are causing these problems, but yet still we managed to survive through it?
Well, I don't think they're necessarily problems. I think they're quite genuinely variations. So certain of these variations in these enzymes will, I suppose they could be described as problems, but only because what we know about is white Caucasians. Most of the research has been done on white Caucasians. So anyone who's not a white Caucasian is less well described by clinical practice. And similarly, anyone who's female or old or young is less well described. It's that sort of a thing. So I would imagine that the variations appeared in response to things that were actually in the diet. In fact, I'm fairly sure that they do in certain cases. So one interesting case that I do know about is that Koreans and Japanese are genetically very, very similar, but the starting dose of warfarin is, now I think I've got this right, much higher in Korea than in Japan. So purely genetically, this shouldn't be the case. But there's a huge difference in the amount of vegetable in the diet. And so therefore, there's a huge difference in the amount of vitamin K in the diet. And therefore, there's a huge difference in the amount of warfarin that's required. So there are, I mean, that's purely dietary. That's not a genetic variation, but I would guess by extrapolation, if you've gone back squillions of generations and you've got one particular diet that has one particular toxin in it that you badly need to get rid of, then you're going to develop a different canon of liver enzymes from somebody who's not got that toxin. But I don't think we're talking really problems here. I think, you know, one person's set of SIPs is no better than another person's set. It's just as is usually the case, if you're pretty average, then the drugs are going to work better for you.
Yeah. I was thinking more in the lines of maybe I'm a bit biased because I did some research on these CYP enzymes before, but I was mainly looking at the genetic variation of these CYP enzymes and how they were actually affecting the outcome in breast cancer patients who were using tamoxifen. And within those, obviously, if you don't have the right makeup of the gene, you might not be able to convert the prodrug to the active drug, which means that, you know, you might as well not take the pill because you're not going to metabolize it, you're not going to benefit from it. So I was thinking from that lines when I was talking about, I really wonder how we ended up with a sort of selection which led into having individuals who can't, having individuals with mutations on that gene, which is actually having a serious consequence if you're receiving treatment with tamoxifen.
Okay, but you could in principle give them a metabolite?
Yeah, of course. Or use another drug that doesn't need that conversion.
Yeah. Okay. We've got something on the chat.
Thank you very much, Jill.
Okay, cool. Thanks a lot, Aisha.
Yeah, thank you very much for your time. I really enjoyed it. I'm sure everyone who watched it really enjoyed it as well. I do appreciate the time that you have spared for us, and thanks for sharing the data that you had with us as well. And hope to have you back when you have more updates, maybe more data on the Caucasian population or other populations that you might work with.
Yeah. Or ask Zubaida or Brahim. Get one of the young people.
Yeah, why not?
Yeah,
cool.
Yeah,
why not?
Yeah,
thank you very much.
Well, thank you. Thanks.
All right. See you later.